together and kind of figure out our substance use issues. And then so that's part-time, and then my other part-time, I'm a CSW intern right now, finishing up my master's degree. So yeah.
So I'm Dr. Maren Wright Voss. I am one of the founding members of the HEART initiative with Utah State University. And so Utah State, if you're not familiar, is a land grant institution that has extension offices across the state. And so in the past, that's been more sort of agricultural and youth programming, but they've started to focus more on health. And so they hired a set of 5 faculty in health extension, advocacy, research, and teaching, and are really expanding their influence into the health realms, partly because they have those community connections with all of agricultural and rural Utah. So I was one of those first faculty, and they asked us to work on the opioid epidemic. And so we've acquired quite a bit of sort of grant funds to try to bring expanded programming. We have this tribal rural opioid initiative that is addressing some of the opioid issues. I serve mostly Tooele County, but we have partnerships in the Uinta Vernal area as well on that specific programming. And one other area that I've been able to find a lot of success in is expanding workforce development, particularly for paraprofessionals in the substance use treatment area. And so we have some statewide programming to expand those treatment professional programs.
I'm Beth Howell. I'm an addiction psychiatrist, addiction medicine specialist at the University of Utah. Been working in the area for a long time, almost 40 years, and not here in Utah, but in different places. And I am the director of the Addiction Medicine and Addiction Psychiatry Fellowships, which is what we educate physicians after they finish their 4 years of medical school and then their training in whatever, and then they go do an extra fellowship year in addiction.
And I'm Lauren Prest. I'm an addiction psychiatrist, addiction medicine as well. Dr. Howell trained me. I did her fellowship program. I've been in Utah for Moab for a couple of years now. I'm their medical director at Moab Regional Hospital for mental health and recovery services.
And I'll just plug in because these guys aren't giving themselves enough credit. So all 4 of these individuals are involved in HRSA's Rural Communities Opioid Response Program grant program. So Cecilia and Four Corners are our lead organization in Carbon, Emery, and Grand County. Cecilia is our director in that area and has done some excellent work. I really credit Cecilia with helping us actually keep moving forward somewhat during the pandemic. Maren managed the grant she's referring to. She manages another grant like ours in those counties. Dr. Howell's our medical director for our UROC program, and she doesn't give herself enough credit. She is one of the, if not the leading addictionologist in Utah. And Dr. Press is doing some incredible things in Moab right now with building just an amazing clinic for addiction and treatment. And it's just, my understanding, I don't know, I think we came together you came into your job just as I was getting started in this, but my understanding is there really wasn't much in Moab for treatment. And Dr. Press has secured some grants and is growing the clinic and just doing some amazing work. So these are 4 of our leading experts in the state of Utah on addiction, substance use, and opioids. So we're really happy to have them here. So the way we're going to structure this is I've just got some questions. We're just going to have a conversation. So I'm going to ask some questions and you guys can kind of choose if you want to just go down the row and answer them or just freestyle it. And I've got a few questions we can get as far as we can get through that, and we'll just have our panel discussion here. And we'll wrap up, I believe we wrap up at 10:45. So we'll just go right up to that time and not hold anybody up for my break. Yeah, 10:45. So the first question is kind of pertaining to the theme of our conference, but what changes have you seen in your community regarding practice environment for substance use through the pandemic? How has that changed? What adjustments have you had to make? How has that impacted your success rates and the way you've been able to work with patients?
Well, I don't know. My environment, I feel like, is a little complicated because we didn't have anything when it came to substance use disorder treatment. And so as soon as I came to Moab, the pandemic broke out. And so we were building programming through a pandemic. And so it wasn't like we had much to compare to. I think it's been helpful, obviously, because as most of you are aware, things have gotten worse in a lot of ways from a behavioral health and addiction standpoint. So having the opportunity to be actively building and being proactive in the face of that, I think has been really powerful for our community. But I can't tell, like, when the pandemic, hopefully comes to an end at some point, will we feel that there's less pressure on us? I don't know, because we've been sort of building through it at this point.
I think for us, it really changed how people got care. And it increased, the level of telehealth, obviously, that we were able to use. We were using very little of it, and it just astronomically increased. In fact, we switched 100% to telehealth. And it was interesting because for so many years, people were like, oh no, we can't do telehealth. There's this and there's that. All of a sudden, we had to if we wanted to see anybody. And I think initially we just said, oh, well, we're going to put it on hold because it'll be better in a month. And here we are, however many months into the whole pandemic. So we did have to do a lot of shifting. I think that's actually been beneficial for a lot of patients. I have patients who live long distances away from me, and they like having the option to do telehealth. Some of them are saying, I really want to come back and see you in person, even ones from, out of state and that kind of thing. But I think the stress for our patients was really extreme because if they were active in, mutual help groups, support groups, they all shut down. They all became, first of all, they stopped and then they became virtual. And in the hospital, when I was working inpatient, many people would come in and had relapsed after some long sobriety because they were just so stressed by the pandemic in so many different ways. Either, they had to be home with their kids, or they didn't have a job, or their job had changed, or they've been laid off, or whatever, or they were immunosuppressed and they had to stay home for that reason. But whatever, it was a big relapse factor for many, many people. And one of the biggest issues was, I can't be with my people. They're the ones that helped me stay sober or abstinent. And now I'm just sitting in front of my computer and I don't care how good Zoom is, it's not as good as being in person. And overdose deaths went up. Fentanyl hit harder in Utah during the pandemic. I think that's really when we started to see it taking off, and we knew it was coming because it's been in the East for a lot longer, but we've now, we're having to change a lot of our practices because of fentanyl with detox. I don't know if you've had to do the same, but it's, so there are a lot of different layers to it. And those are the first things I think of. I'm sure there are many others. But I'll let.
So I don't have as much clinical association because I come more from the academia and sort of training and development side. But while overdose deaths went up nationally, Utah Department of Health just recently came out with their most recent numbers, and they saw that there was no increase in overdose deaths that they could report, or suicide deaths.
And in Yemen County,
They decreased. But in Tooele County, where I do most of my work, we just saw the 2020 numbers, and we went from about 20 overdose deaths per 100,000 to about 28. So for us locally, we saw a huge increase. And what we heard reported from the clinics was some of the same things that you're mentioning. The extra stress, the isolation, definitely our local recovery groups were shut down and people weren't getting the support that they needed. Fentanyl.
Why is it going up?
Exactly, compared to other areas. I'm not sure why, but the fentanyl is hitting hard, and we're seeing that in the drug supply everywhere, which of course increases the overdose risk. But we're just hearing from people that isolation and the extra stress. And so it seems like a time when there needed to be more support, and at least for us in my small area of Utah, it hit harder and we saw more overdose deaths because of it.
So I'm in our area, hopefully my lipstick isn't all smeared on my face now. So if there's any pictures, be mindful of that. We echo a lot of what Dr. Hal has said. So You know, we have 3 different clinics, one in Carbon, Emery, and Grand, and organizationally, there was a lot of change. We had to figure out how to, you know, the cost of it all, like putting up plexiglass, buying masks, making sure everybody was safe in that way. At our OTP clinic, we had to really be mindful of, you know, they're a high risk population. We want to make sure they're safe, and they still have to dose every day. So we still had to, move forward with operations. And we, you know, we had to figure out telehealth. Telehealth was a huge benefit for us in this whole thing, and also difficult because of internet access with our individuals. And you know, a lot of our clients are in poverty. They don't have access to internet. They don't, you know, they don't have those kinds of privileges that a lot of other people do, and just internet access in general in rural areas. And you know, our connections all the time are spotty, and so you know, doing groups and managing groups is difficult because you know, you're like, I can't hear you, what'd you say? And so it's just that you know, personal connection piece is broken a little bit. And so that's been a huge adjustment for us. Also just belief systems and ideals of our culture in the area, and you know, the belief systems around the pandemic and in general, and not just from our clients, but also people, you know, our professionals, our administrators, our staff. There's a lot of inconsistent messaging, and so it's difficult to come up with a consistent plan when there is, you know, these messages coming down from the pipeline of, you know, just what's correct information and how do we convey that. You know, we're constantly working on educating our clients on just their brains around substance use and mental health in general. And now we kind of have to add in this healthcare piece, and we're not healthcare professionals, but we have to be, you know, we have to provide this information in a way, but it's constantly changing. And so it's difficult just all the way around to get a consistent message to people. And so trust has been not damaged, but just a little shaky. You know, what is the consistent message? What's correct about it? What, you know, and then you have leaders in the organization who have different belief systems about it. So there's been a lot of different aspects that we've had to look at and overcome in this. And now we're having to do it all over again because our rates are climbing of COVID cases in our area. So we've had to shift a lot more to telehealth again. And that connection piece again is shaky. And so, you know, and the cultures in each area are so different. Like the culture in Grand County is so different from Carbon County, which is so different from Emery County. And so, you know, our organization covers all 3, but we have to like figure out how to, you know, yeah, anyway, a lot of changes, a lot of things we've had to figure out. So.
We definitely keyed into some really good themes there that I want to have some follow-up questions on, but one of the ones we've got prepared here is, we touched on this, but how are substances more or less accessible because of the pandemic? And if we can touch on, we know fentanyl is increasing, but like the types of substances they're accessing, like are prescription medications more or less accessible, and how is that interacting with illegal substances, and how's that changing the landscape with the types of substances you're seeing?
I mean, nationally, I think we're seeing that prescription opioids are down, right? It's been like a 40% reduction, I think. But we're seeing that fentanyl rates are so high, right? So we're still seeing that overdoses are increasing despite this change, that practitioners, prescribers are changing their habits, but it's not really impacting opioid-related death. I mean, certainly I think that this is partly a pandemic response, right? That everybody's stressed, and who's impacted the most by stressful environments, the most vulnerable, the most marginalized people, and that's our people, right? And so those are the folks that are going to end up having higher risk behaviors and more negative outcomes, morbidity, mortality. Right? So I would say fentanyl, of course, is through the roof. And we're seeing that the fentanyl is in everything, right? It's in the meth, it's in the weed, it's in everything. So it's not just the pressed M30 pills or whatever, right? I would say meth is pretty easily accessible in my community. I can't think of any. We're seeing a lot of cocaine, which feels random for Moab. So I don't know, I can't say that drugs are like harder to get right now. In fact, it's probably easier because there's a market for it in potentially a way that there wasn't 5 years ago.
And then population growth, it's.
Well, Moab's population, I mean, I can only speak for my area, is pretty steady. Our tourist population is through the roof, right? We're talking 3 to 5 million people a year. So, which really adds a lot of variability into our dynamics.
Yeah, it depends on where the tourists come from
Yep.
and what drugs they bring.
Totally.
I think maybe drugs were less available and I felt like more people were drinking, but then I think they figured out where to get their drugs. It didn't take very long. But I agree pretty much with everything you're saying, that we've just seen this gradual rise in fentanyl in everything. People are always surprised when they turn positive on fentanyl. They're like, I just smoked meth. Well, the meth had fentanyl in it. And it just makes it a lot more, it's like a crapshoot. It's always a crapshoot with addiction, but it's even more so because people don't really know what they're getting. And it's not just fentanyl itself, it's that there are all these fentanyl analogs. And we had a week recently where we had some really weird reactions for people going through detox. They were taking the M30s, but it seemed like there was something else in it that week, you know. Right, yeah, it could have been. It just got checked for fentanyl and we can't get a rapid fentanyl, that will tell us what the exact analogs are. But I think we're kind of at the mercy of whatever analogs are coming into the state and in the area. And yeah, it's just been.
Do you think people would still do the drugs if they knew fentanyl was in it, if we had wider?
Well, I can speak to that.
please.
Utah Department of Health has been providing fentanyl test strips. And so through our Utah Syringe Exchange, they've been supplying those. And we're not getting a lot of people wanting to use those in our Tooele community. But what we've heard from UHRC, the local syringe exchange provider that supports Tooele, is that it's not a deterrent. When they test positive for fentanyl, they are saying that that's an incentive to buy from that supplier.
Right, because they want the more powerful drugs. And so, and the scary thing is, and this happens a lot, like it sort of reminds me of the whole crack cocaine epidemic when it first started. People were snorting cocaine and then they injected it and then they figured out how to make crack. And then it's like people's consequences would happen within a few weeks or a month instead of a few years. And overdoses, I think, are happening faster, but there's never going to be enough drugs to satisfy the brains of addicted people. And so we're getting more and more powerful opioids, but the fentanyl analogs are the most powerful opioids we have, or that we know of yet so far. It could change. And so I think that whole range of taking drugs that really get you high but don't kill you is just shrinking, and it is worrisome. Yeah.
And this is a phenomenon we see specifically in opioid using populations. Like, not to say it doesn't happen in other populations, but with opioids in particular, we see that people have a kind of an escalating kind of risk profile as they progress through their illness, and they sit on this line, right, where they're eventually really willing to risk death for the right high. And that's that really scary place, right? And so it's attractive to have high potency opioids
And be
in their drugs.
near death, and if you overdose, it's considered a positive thing. And hopefully there's naloxone around, but it is really scary.
I have a question on exactly what you just said. It's been about 8 years in the Tenderloin of San Francisco, working with harm reduction and needle exchange programs, and have administered the nasal and injectable Narcan. I'm just curious, with fentanyl and carfentanil, how is Narcan's response to those kind of like synthetic opiates?
It is a lot more.
Does it still work the same as well as like a
If you use
heroin?
more,
Yeah.
It works, but
it works. We do the harm reduction program, needle exchange in our health district, and it works. You just have to use more.
And in response to this issue, the FDA recently approved a higher dose
a
naloxone.
higher dose and they extended it from 24 to 36 months, they extended the expiration date.
Yeah, and yeah, and it's just getting it out there, but if you're by yourself, you're not gonna give yourself naloxone. And, you know, the window of time that you have to give naloxone is a lot shorter too. And so you may be dead within a few minutes versus you may be able to kind of intervene over a little bit longer period of time for people using other opioids. So it's, yeah, it's scary in a lot of different ways. And the other thing that this brings up, and it's interesting you mentioned San Francisco, because I was talking to some people about capacity for people to make decisions. And one of my friends from San Francisco said that California, this kind of blows my mind, is thinking about looking at laws to force people into treatment, because they have people who will overdose 3 to 4 to 5 times a day. They'll go to the ER, they'll get revived, they'll go back out, overdose again, go back. And it's like, they feel like those folks are kind of in this death spiral with their addiction, and could they involuntarily commit them? And there's a big controversy within the addiction field about whether or not that's appropriate or not.
Yeah, safe injection sites are a big thing. I mean, I've had individuals that I've administered, you know,
Yeah.
chronically homeless, mentally ill, you know, for so many years that I had relationships with, that just begging them not to, waiting on the paramedics to have the stronger, you know, like the more the dose, and they would use right there while I was chatting with them, you know, just begging them not to. So I can totally understand.
Yeah, well, that's
people
the
consciously
addicted
looking at
brain is gonna use drugs. I mean, that's what addiction turns your brain into an instrument that's trying to kill you. And so why are we surprised that people will do things that are potentially fatal? Yeah. And getting closer and closer to that edge and looking for the things that can kill them easily.
And end stage addiction is real, right? I mean, it's kind of parallel to cancers, right? Like where people just really get to a point where psychologically and physically they can't do it anymore. I had a patient recently die who he told me 2 months before he was going to die. He just kind of said, "I'm not going to make it." We don't have methadone in our community yet. And we got him into Grand Junction, but the drive is too far, and he died, and he just couldn't do it. So.
Yeah, and I think it'd be nice, we should write an article about end stage addiction, because I use that term and people say, well, how do you define that? And I think we all know what it is. It's like, you know it when you see it, but I don't know that there's a definition out there. But really, these are people whose brains have gone so far into the process that I don't know if they can even be clawed back, you know.
I don't think their reward centers work anymore.
You're not even
if
getting
they-
higher, like you're just getting back to normal. So I mean,
Right,
you're
yeah.
at such a stage.
You're trying to feel
Death
normal.
is probably a relief to the pain of being so dope sick.
Right, you're gonna say.
So if they did start, like California's thinking, and kind of force them into rehab, would it work? Would it be able to help them, or?
You know, I don't know that we know, but it's sort of like saying if somebody comes in with a severe heart attack that's progressed past a certain point, you wouldn't just say go home and deal with it. You'd put them in the hospital, and they may or may not die, but at least you're going to try to intervene. And I don't think we have enough of that approach with addiction. The other thing is that it often doesn't work well if you don't have coverage. So Medi-Cal, I'm assuming, would cover a lot of these people. With our Medicaid expansion, we have more options to do that. But up until about the Medicaid expansion, this would never have worked here because there was no place for people to go and they weren't going to get coverage. I used to work in South Carolina. That's where I trained. And many states actually have a commitment law for addiction. It's very different from the mental health law. It's not as long, but it's just to keep people in treatment long enough to kind of have their brains clear up a little bit, you know. And so it's not a month. I think in South Carolina, it was 2 weeks and that kind of thing. But it's kind of an unpopular thing to take people's civil liberties away. And so I don't know if it would ever get any traction here.
Can I share something? share something on that topic. We did some interviews in the Tooele area, and a very surprising finding was people who'd been in recovery had 100% endorsement of incarceration as a positive for their recovery journey, which we think of that as a negative experience. And I don't know what the drug supply is in the Tooele jails, that these individuals felt like they made it through recovery, but 100% endorsement of that as a positive experience that helped them into recovery. So a place where all choice was taken away worked for these individuals.
Yeah, it stops you short, and something that stops you short can be a real change agent.
Well, and it's the antidote. Abstinence is the antidote for this disease. And
Yeah, well, you're not always abstinent in jail. I mean, you can get plenty of stuff.
The
in jail.
concept is.
But less stuff.
Yeah.
You can't just call up your drug dealer and have him or her deliver in jail.
But 30 days then is a period of time in which the brain can get to a different place.
I've heard,
I see the problem with that, like, I think it's a great motivator. Jail is worked wonders for so many people. Yet when they then get into recovery, they have charges, which then ends up setting them back because they now have a criminal record and they can't get housing and they can't. It's such a double-edged sword. So it just would really be cool if there was something that there was just
One
a
of the things
space
that you
rather than charges. There was a space for them to be
Mhm.
away from that.
One of the things that Utah's looking at when we receive the dollars
The
from the
opioid.
lawsuit with Big Farm is being able to help people be able to afford to get those charges expunged.
But that's still a lengthy process, and what do they do in the interim?
Well,
Like, what do we do with the population while they are in recovery, they're out of jail, they've completed their program, they cannot get into housing?
It doesn't have to be a lengthy process is what we're hoping
Right.
for. And the reason why it's a lengthy process is it costs a lot of money. And if you're a person in recovery or you're living in housing, you don't have those funding dollars. I mean, for each charge, it's gonna cost you over $1,000.
So USAR is working hard on that very bill. And it will still be that they have to go a period of time with those charges before the extension.
Sure, that's how it's written now. So it doesn't mean that that can't change, and it
Right.
doesn't mean that Utah itself, I just received a document for that specific budget.
Cool.
To be able
Good to know.
to reduce those charges, to move people through that funding process and eliminate some of the timing that's required until you can apply for expungement, right? Which will definitely be a huge improvement for folks that are trying to move through. You can't get a job because you have a felony. That shouldn't really be the case. We can get those expunged.
Right.
And quicker and more.
I just am sharing that, like, that's the biggest obstacle that people within the catchment area that I cover with Sarah. That's the biggest obstacle currently, and I know that this is in the future and it's coming, but still, it's like, it's so difficult because then they start to give up that hope. They start to lose the hope because there's not housing.
So
And
2
the-
years ago,
So
we
I
had
think that
attorneys did a huge expungement. They had so many people, they had to turn them away, where they paid for it. The attorneys themselves paid for that or had those expungement fees waived.
But you're
And,
right, that
But
the
thank
addiction
you.
commitment is an alternative to that,
Yes.
where they can have that 30 days of.
Well, and also, I mean, yeah, the commitment stuff could help, especially if there was a longer term commitment and you could say, hey, I'm under commitment. If I relapse, then I'm gonna have these consequences, kind of like drug court, but not exactly. So I think there are a lot of things we just haven't looked at here that could be helpful. And of course, starting a methadone program and rural, I mean, I think once your program gets started, we'll have more rural methadone than any other state in the union, I think.
Well, and Tooele is also in the stages of trying to develop a methadone clinic and
Good.
looking to Moab to say, how are you getting this going? So very excited for Moab's clinic
We'll have
to,
Nate down.
exactly. We're excited to be working together and getting that out into rural Utah.
Cecilia had a.
I just wanted to
another
add one more thing, going back to the risk of, or the access to drugs and the pandemic. I echo exactly what these doctors have said. And also one other concern that we're facing is with the increase of fentanyl in our area and risk of overdose, on top of the pandemic, on top of the belief systems in our areas around like, is this even a real thing? We have a lot of hospitalizations from COVID. Which then if we have overdoses, things like that, what's our healthcare capacity? How many beds do we have at the hospital? Are these individuals going to get the treatment and help they need because of, our lack of resources? So it's just overall, rural areas and our resources are thin. Adding in a pandemic, it makes it 10 times harder as well. So.
Plus people they're just in general delaying their healthcare. So in the hospital, we would see people just a lot sicker than I think they would have been before. I don't know if you saw that in Moab, but
I mean, I feel like there's so much stigma in our area that people just really don't come. They don't come to the hospital. They'll avoid the ER. They'll talk to my team and that's it. And if we can't solve their problem, that's it. They won't. But we are introducing more and more advocacy where we go with them to the ER and we meet them there and we do the liaison work so that they can get their needs met. And we love our USARA people because they do that kind of stuff too.
We love you.
So there's nothing like lived experience, peer support. You got to have it in whatever you're doing.
That's the workforce development program we support. Get more of those peer support out there. They're so critical.
and we did still at the U, we have a bridge program where people can show up to the ER and get started on buprenorphine or get referred, but and that continued, but it really changed a lot. It became more telephone. And I think that what happened, what we're hearing is people are going to their follow-up clinics and they just want the meds. They don't want to do any counseling. They don't want to talk to anybody, nothing like that. They just want the meds, which is a real important component, but not everything.
What are rural people able to come to the University of Utah and do the bridge program?
We've had people from out of state come to the bridge program. But the issue is that our partners are with mostly in Salt Lake Valley area, not just in the county, but so it's not really specific to a county, but realistically, we're not going to have as many options that we're familiar with that we can easily transfer somebody to, because the bridge funding is only for a month. And then they have to go with their Medicaid or private insurance or nothing, whatever, out to a provider in the community.
We'll talk more about that because that's
Okay.
As we're moving into kind of the last phases for this breakout session, I want to kind of shift. There's a lot of negative things that we've seen, a lot of hardships with both the pandemic and the substance use treatment. But can we talk a little bit about some of the unique solutions and innovations that you guys have seen over the last 2 years as we've moved through the pandemic regarding substance use?
I would say for us, it's community partnerships. We've really, I'm proud of our area for all of, a lot of agencies coming together and really working together on this issue. Our university has the extension, the Heart extension, and they do a lot of community education. They've done community education dinners, and community partners really work hard to get the word out about those so that we can educate our community as a whole and kind of reach a broader audience so that individuals can learn about addiction, learn about substance use, learn, change the stigma, reduce it, get more education about the addicted brain and things like that. So I'm just really proud of our area that we've come together to really solve this issue. And I think it's slowly shifting. I mean, it's a process. It's not going to be an overnight thing, but it is shifting ideals and really helping people get access to treatment.
And I don't know if it's COVID related or just that the overdose deaths aren't stopping, but law enforcement has been really getting more engaged in the conversation. So our jails are allowing us to come in and provide naloxone kits to every person as they leave. We're working with them on trying to get some of the infectious disease screening available to the residents there. And then we have like a harm reduction summit that's coming up next month that they're co-sponsoring and paying for their deputies to attend, just really engaged in knowing that something needs to change.
Yeah, I think in the last several years, I don't know if it's pandemic related, but I think law enforcement kind of reached that peak where they realized, I'm not going to be able to arrest, or we can't arrest our way out of this problem. Well, duh, we could have told them that 40 years ago, but still. Anyway, you have to kind of learn these things on your own. I've seen, more interest in medical professionals who kind of come to the conclusion that a lot of the issues that they deal with on a day-to-day basis are related to addiction. And if they don't deal with the root cause, then it's not going to work. However, they have a lot of weird ideas about how to deal with the root cause. And so we have ongoing challenges in training medical professionals about addiction. I haven't seen a lot more people become waivered or start providing buprenorphine. There's not been this big rush to do that. And I think having the methadone program start in Price and then also coming in Moab, it's going to make a big difference. I think stigma is maybe getting a little bit better, or at least it's not where it needs to be by any means. And I think on a one-to-one basis, it's still really bad. I mean, even in RER where we have a bridge program, I still hear stories about patients getting stigmatized, but I agree that having USARA or a peer support person with them really helps. And that's been one of the bigger changes that we've seen. I mean, it's like, I can't even imagine going back like 5 or 6 years without not having USARA there to help us. It'd just be unbelievable.
Yeah, I mean, there's updates all over the place, I guess, in the last year, like, like mobile methadone is now approved. You can do a notice of intent instead of getting waiver trained, for providing buprenorphine. There's new research around like Vivitrol and Wellbutrin combinations for methamphetamine. I mean, there's a lot of things that have happened even in the midst of a pandemic. But I think the biggest thing is, the changes around MAT access, and anything you can do to reduce barriers to that access is really when you start to save lives. And that includes the stigma conversation, right? Is how do you change language or in an organization and in a community? And I think that goes back to the collaborative kind of intents, right? Is talking, like I talk to my drug court judge. She knows me, she trusts me now, she sends me people, she does what I tell her to do, instead of, the opposite. So, and that's cool, right? Because that means that now patients can stay on Suboxone during drug court and they don't lose their children. And that's huge.
Just language is so vital. There was a moment in the ER when the doctor had come in and asked, "Are you shooting up?" Like, wait, I spoke up and just said, "Would you mind rephrasing that?" And just asking if they're using IV drugs. Like, it was just because I felt the patient just was like, just literally melted away. And I was like, we're going nowhere with this. So it's difficult because the doctor was really resistant, but it just is moments like that are teaching moments. And I think that we really have to. So I appreciate that you've made those strides in some of our really smaller communities here in the Southwest region. It's really difficult to break through some of that stigma with just changing language. Education. And we have a great, USAR has a great education of our language presentation.
And you
But
really
it's so
need
hard.
you really need to do it in the moment. I was presenting about a week ago or so, and someone whose son died of an overdose said, well, when you have a drug addict come in and they're doing XYZ, and I'm like, can you change what you just said? She's like, oh, and it was like an aha moment. This person also is a healthcare professional. Like, you need to look at your language, because that's what I was actually talking about. And it's just automatic to come out with this kind of angry, pejorative, term that, And it was a teaching moment for her. She was not offended, but I've even had one of my fellows this past year said, well, so-and-so is a frequent flyer. I said, no. We don't use those terms. Friendly face, familiar face. I mean, whatever you want to call it, if you like FF as the, abbreviation, that's okay, but have it stand for something else.
Nobody thinks they know mental health and addiction. I mean, you talk about like gastroenteritis, nobody's like, I know all about that. Let me tell you what those patients are like, but with this group, people think that they know because everyone has a lived experience with it or with somebody that they know who struggled with addiction or bipolar disorder or whatever. So even you're in the grocery line, right? People have a story to tell you.
Yep.
And they talk about it with authority, right? And so it's really challenging when it's something that, but I think in small communities, we do have a little bit more power maybe because we can reach each other in ways that you can't necessarily in bigger communities. So even though there's more stigma, maybe there's more hope. Right?
I have a personal story to share regarding that. I was talking with a family member and she was upset about something and she was like, I have common sense and sometimes I figure I think that's way better than having book smarts. And at first, I left and I was like, kind of offended. I was like, are you saying something about, should I be feeling bad about my education? But then I thought about it and I was like, there's this, it's this idea, it's in the culture, it's this belief that, common sense is the right thing, it's the information, the right information, but there's a difference between common sense and misinformation. And that's not connecting, and so the changing of language, you're changing belief systems, you're changing these ideas that have been pervasive for years and years and years. So while it's easy to get how could you ever say that? It's you have to see the other side of the coin. This is something that's been, this is a belief that's in this culture that's going to have to change. And it's not impossible. It's not that it's impossible by any means, but it is a process and it is going to take time.
And I also think we need to honor families and communities in these ways because we may believe that we know what's going on, right, as professionals that are engaged with these folks. But honestly, the families and communities have been absorbing the repercussions of substance use for so much longer than we've been involved. So we have to give them a little bit of props for having absorbed all of that trauma and chaos for so long and allow them to have their kind of negative feelings.
Yeah, and sometimes, sometimes I'll do something like, when your loved one does X, Y, and Z, I said, that's really because this particular part of their brain is not working. And I'll try to, what they're angry about or whatever, stigmatizing about, and then try to get it, say it's really more medical and it's, but try to tie it to something that's specific to them. Sometimes it works, sometimes it doesn't. Nothing works.
Pissed off sometimes.
Yeah, people just want to be pissed off. Yeah. Yeah, Ty has a question.
Oh,
Yeah, and not to change the topic, something Dr. Press said earlier caught my attention. I'm a hospitalist at Primary Children's Hospital and did a lot of adolescents and more. And, THC positivity is almost ubiquitous. And you talked about marijuana laced with fentanyl. And I wonder, do we have any idea what the implications are for that in the long run now?
I mean, we know a lot about early exposure to substance use and what that does to the adolescent brain and trajectory towards substance
Sure.
use.
I mean, can they become opioid addicted just through smoking marijuana? That's, even unbeknownst to them.
So we had a 13-year-old boy in Carbon County overdose from smoking his cousin's marijuana that was laced with fentanyl. Now he didn't die, right? So that's going to be our next ideal, is our next.
Fentanyl into the hands of marijuana smokers now, it's almost really daunting.
So what we do with our harm reduction clients, when that happened, we asked our harm reduction clients to test their marijuana with the fentanyl testing strips. And it was probably at that point about 30% of their marijuana had fentanyl
So
in it.
should I be giving naloxone to families that have kids?
Yeah,
Yes,
I would.
Yes.
And here's the thing,
We're not. That's
They're
an
gonna be
interesting thing. that you're
unaware,
doing.
no one, you're people who smoke marijuana, however you feel about it, right? They're completely unaware that, soon their marijuana, most marijuana will have fentanyl in it. It's a market plan for the cartels to ensure addiction, and especially as we move forward towards legal marijuana. And we all know that at one point Utah will have recreational marijuana, maybe not today,
Safer.
tomorrow, but it will move
At
there.
least it wouldn't have fentanyl
It
in it.
almost feels like
It could be
a
a harm
reason.
reduction.
Yeah, it almost
You know?
feels like a reason to legalize marijuana
Yeah.
because you can do harm reduction
That's
and
how we
say,
feel
get
at the
it,
health
get
department.
it from somewhere where you know it's not.
So you
laced
don't
with
get
fentanyl.
the fentanyl.
Take
in
away
your
something
marijuana.
like that.
Yeah.
And we had a
Yeah,
couple
that's the
of
money and
kids
education.
in Colorado die from smoking marijuana laced with fentanyl. And here, this is what we see.
Where it's recreationally
Yes,
legal.
yes, this is what we see. So our harm reduction clients have a tolerance to fentanyl, you know, a little bit, but our babies do not. Our 13 and 14-year-olds who are going to start experimenting with marijuana, even more so as we socialize it. They don't have a tolerance to fentanyl, and they don't have knowledge that it's in there. And so we do need to start creating an educational campaign in regards to that.
You know, and legalizing still, even in the states where cannabis is legalized, there's still a big black market.
Right.
And so,
And it's cheaper.
and it's cheaper on the
Way
black
cheaper.
markets. We're not solving, I mean, I'm not saying one way or the other, but
Yeah.
you know, if you legalize, it's not going to be a panacea because there's still going to be drugs out there that are not through the traditional channels that are could be laced with whatever.
So in Utah, when you go to a marijuana, and marijuana stigmatizing, so I need to say that right. When you go and get your medical cannabis, it's $85 for an eighth of an ounce. Well, it's not gonna cost you that much on the street.
Right. And it might have fentanyl in it. Woo! So you can 2 for 1, you can die from your smoking marijuana.
So
Pay a premium for fentanyl-free marijuana now, I guess.
Yeah.
Charging
Members.
$48. We've come to the end of our time with the panel. There is a 15-minute break if you guys want to have any conversations kind of in between, but I want to thank our panelists again. Give them a round of applause. To the other, those that came to set to the session, I know, as I mentioned, these are 4 really leading experts. We have other experts in the room as well. Debbie and her team know an awful lot about this as well. And I've much of what I've learned about substance use, I've learned from Deb, from her teaching these things. And having Marcy here with you, Sarah, has also been great and added to the panel. So I appreciate you guys coming too to help add to that.
You guys need it.
Yes. Everybody's got through this problem, so it's good to have interactions beyond just the panel, but we